Okay. For the health of it, do you have all your members? Are you ready to go?
I think so.
Okay, wonderful. We'll start the time when you begin.
We are For the Health of It, and we are a multidisciplinary team tasked with preventing cancer and promoting health within the Nashulai Maasai Conservancy. Our program will be called CP Med, which stands for Cancer Prevention through Maasai Education. The Maasai people are traditionally nomadic and rely on the Maasai Mara ecosystem of southwest Kenya to raise livestock and sustain themselves. The Conservancy covers 5,000 acres and is home to around 1,500 people. The mission of the Conservancy is to conserve wildlife, preserve culture, and reverse poverty while centering the Maasai people. We were tasked with combating cancer, focusing on the elder population, and using a community-based preventative approach.
Cancer is a growing health concern for the Maasai elders, accounting for 10% of deaths in Narok County in 2019. Among the most prevalent are breast, prostate, and esophageal cancer. The rising incidence of cancer may be attributed to poverty, environmental conditions, and behavioral risk factors influencing diet and physical inactivity. Barriers to accessing care include the lack of cancer care infrastructure and physicians, and the lack of awareness among the population of risk factors, common prevention, and control strategies.
You all are most likely familiar with the levels of prevention model presented here. It is widely accepted that prevention is much more economical and sustainable than treatment. And the most feasible way to address cancer in the context of the Maasai people is to focus on primary prevention. We have allocated the majority of our resources towards primary prevention efforts while still recognizing the importance of secondary prevention. Our proposal focuses on cancer prevention strategies for the entire community while centering the elders throughout, and also prioritizing the youth as they are future Maasai elders. For these reasons, we consciously decided to focus on primary prevention as it will save the most lives in the long run. To ensure we are centering the community with our approach, we will spend at least the first 6 months in the planning phase. First, we simply want to build trust with the community through casual conversations with Maggie and Nelson, the Conservancy's co-founders, and the elder population as they will influence community buy-in. After all parties agree trust building is complete, we can move into assessing community strengths and opportunities for growth. Some of the opportunities for growth include underutilization of the local clinic, a diet lacking in nutrients, lack of economic growth, and young people moving to cities at high rates, leaving the elderly uncared for. The Maasai are experiencing increased rates of cancer and attribute the recent rise to lifestyle changes and environmental exposures, which we plan to focus on in our intervention. We then plan to gather information directly from the community by holding focus groups and conducting key informant interviews. Nelson and Maggie will help us facilitate gender-specific focus groups with older adults and key informant interviews with clinic staff and traditional healers to help us identify gaps in knowledge and care. All of this will ensure a successful rollout of our intervention, as we will be able to tweak our projects based on community feedback, compare our final evaluation to our initial understanding, and meet community expectations.
We use socio-ecological model to set up our goals and intervention for this project. On an individual level, our goal is to improve the lifestyles of Maasai people, especially Maasai older adults, through our community Camels intervention. On an interpersonal level, we want to increase access to resources by educating the community to provide caregiving to older adults and assist them with transportation when needed. On a community level, we want to foster relationship and reduce stigma by facilitating series of dialogues among different stakeholders. Finally, on a societal level, our goal is to combat poverty and empower women through our intervention microfinance. First, we will introduce you to our community Camels intervention.
Kenya is home to more than 3 million camels, nearly 10% of all the camels in the world. So why not utilize this resource? These animals can hold weights up to 600 pounds and can walk about 20 miles a day. Camels have previously been used in other parts of Africa as mobile health clinics. Based on the positive perception of its previous use, we plan on converting the mobile health clinics into a mobile education unit. Our community camels will play 3 roles. For education, we'll be educating the Maasai on cancer risk factors in the community. This will include setting up tents and teaching about the importance of nutrition and clean water, as these are some environmental factors that can contribute to cancer. For nutrition, the traditional Maasai diet consists almost entirely of fermented milk, meat, and blood, all of which can pose a cancer risk. In addition to teaching about nutrition, our camels will also distribute supplies to help create cone gardens, which will allow access to fresh produce and food security. And lastly, for employment, we will also be creating employment opportunities by employing the younger population as camel health workers and teaching them to fulfill this role at the existing health clinic.
Now we will discuss the interpersonal component of our intervention, which is providing caregiving to the elders. In the Maasai community, younger individuals have been relocating to cities for employment opportunities, leaving no one to care for the elders. Therefore, we propose to provide training to caregivers to assist elders with performing daily activities such as dressing, grooming, preparing, and serving nutritious meals and companionship. This will foster and strengthen community intergenerational connections to better address the needs of elders with chronic illnesses such as cancer. The second component addresses screening. Based on public health guidelines, the community health workers can train the caregivers to assess the need for screening and utilize the motorbike we provide for transporting the elders to the nearest hospital and increasing access to care.
The next level of our intervention will occur at the community level. Kanya Ijoto translates to what do you mean in Ma, the Maasai's indigenous language. One of our goals is to foster relationships and build community, especially between the existing NGO-funded clinic and the community as the clinic is underutilized. We plan to bring together 3 stakeholders, including the National Eye Conservancy, the Sekanani Clinic, and community members, including elders and traditional healers. We will train a representative from each group to be a facilitator, and the conversations will be held at the community center and cash incentives will be offered if appropriate. This series of conversations has 3 goals: to build strong relationships, reduce stigma and confusion surrounding the clinic, and develop a strategic plan for combating cancer in the community. It is important for the clinic to explain the services it offers and provide a chance for community members to ask questions. Once the stigma and confusion is dispelled, healers and elders will be more inclined to refer their community members to the clinic. And lastly, we will guide the stakeholders in making a strategic plan to combat cancer in the community. This plan should include continuous education efforts, a policy advocacy plan, and a plan for securing future funding.
The final piece of our 4-pronged intervention addresses combating poverty and empowering women through microfinance. Different forms of microfinance have been successful in empowering women in a lot of developing countries, including other parts of Kenya. Some women in the Conservancy produce jewelry, handicrafts, and clothes that they sell to the tourists, and many others struggle to start a business due to lack of money. A lot of young people are moving out of the Conservancy to find better opportunities. With the help of this advisory board, NMCA will set up a community fund and distribute small loans to women to start a business or scale their existing ones. With an overall 90% payback rate across the board, this project has potential to improve the lives of many. Thus, microfinance can generate money for the Maasai people, which will eventually help them afford more healthy food and seek care when needed.
Our intervention mainly focuses on increasing education and improving public perception of cancer, as our timeline of 3 years and budget limits our capability to immediately address healthcare access. With these considerations in mind, we will advocate for public policy that ensures access to cancer care for the underserved. We will do this by partnering with organizations that target the growing cancer crisis in Africa. Incorporating a policy intervention for improved health infrastructure and increased screenings will make sure that the Maasai people have access to care after our intervention takes place. So in terms of sustainability, our intervention incorporates a mix of economic, environmental, and social pillars that show how our program will proceed in the future. For economy, we'll be stimulating it through our microfinancing. For the environment, we'll be decreasing environmental factors that contribute to cancer, including exposure to chemicals, reducing poverty, and improving diet. And then for social impact, by the time proper health facilities and access are in place, stigma surrounding cancer will have already been addressed among elders and the youth, which shows a lot of promise for the future. And this should lead to increased reception to cancer screening and treatments when it's available. So for stakeholders, a major stakeholder that we have are the community elders. The elders are our target population, and we want to ensure that we efficiently communicate with them to assess needs and approach the community in a culturally competent manner. Other stakeholders include the community center and health clinic to increase education and facilitate caregiving to older adults. We will also hire and train healthcare workers and also partner with aid organizations as a way to generate policy change for future health infrastructure.
In order to achieve these goals, we propose the following timeline composed of 3 phases. As discussed in phase 1, the first 6 months will consist of building trust and working with the elders to gather information. This will include collecting baseline data and input from the community on items such as current cancer stigmas, cancer risk factor knowledge, and nutrition, which will influence phase 2's intervention development and be utilized to examine improvements in these items in phase 3. Phase 2 will consist of our multi-pronged intervention approaches in months 6 to 30. And then we'll move on to phase 3, which consists of evaluation, in which we hope to have some lessons learned and how we can maintain these programs in the long run.
Our budget to execute 3-year cancer prevention project is $300,000. 40% of our fund, an estimated $120,000, will go towards community camels, motorbikes, and gardening campaign. Another $40,000 of our budget will be spent on community health workers, supplies, screening kits, equipment, staff, and office overhead. Of the remaining 20% of our budget, $30,000 will go towards microcredit community fund and $30,000 towards the emergency fund.
With respect to phase 3, we will conduct our evaluation, and this will be based off the REAIM framework, which stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. At the end of phase 1, we want to gauge community interest in participating in the interventions developed so we can identify gaps in the scope of our reach and make efforts to engage more individuals and community partners in the interventions. With respect to effectiveness, the overall goal of reducing prevalence of cancer among the older Maasai will be difficult to directly examine, as it will require more longitudinal data and assessments. So we propose a more tangible method of assessment, such as assessing whether diet changes have occurred, whether there's increased knowledge of cancer risk factors, and if there's individual economic growth in the area. Adoption refers to the use of interventions by the target population. We will collect data on the numbers and proportions of all elderly Maasai living in the Conservancy that have engaged in the practices taught to them, and any reasons that they might have not engaged in adoption. With respect to the implementation of our interventions, it will consist of a reflective self-assessment of our team, particularly as it relates to our fidelity to the proposed intervention. So it'll measure how well we adhere to our timeline, our budget, and our goals. And we're hoping that the information we gather from this will inform any future uses of these intervention plans. And lastly, maintenance involves the assessment of sustainability of the interventions. So we'll collect data on the proportion of individuals still engaging in the interventions like gardening, microfinancing, and the proportion of community partners still providing support 6 months to a year post-intervention. We'll also collect any information on why these interventions were maintained, so the strengths, why they may have been discontinued or adapted. All the information gathered in this phase will provide lessons learned to ensure continued use and improvement of our interventions, as well as inform any future dissemination efforts.
One ethical consideration is that people currently living with cancer will not receive much help through this intervention, but many more lives will be saved in the long run with a primary preventative approach.
Some ideas moving forward would include advocating for national level policy changes that would incorporate environmental health interventions and an expansion of the National Hospital Insurance Fund. Implementing policy changes to reverse and prevent further pollution in the Mara River can address one of the main risk factors of cancer in the Maasai elders. One of the barriers to accessing care is the cost of cancer treatment and facilities, so an affordable and accessible health insurance plan will alleviate some of the financial burden faced by the patients.
Thank you so much for listening to our proposal of CP Med, Cancer Prevention through Maasai Education, and we look forward to your questions.
Thank you very much. I'll jump in with a question. If you wouldn't mind going all the way back, I think it was maybe to your second slide where you showed the most common forms of cancer. right there. So you indicate here that breast, prostate, and esophageal cancer are presumably the way that you've got this set up, that they're the most common types of cancers, or are they the most common causes of cancer deaths? Which is it?
Yes, so the data is very unclear about the Maasai community specifically.
Okay.
This was taken from the information in the case about Narok County. So that's,
Okay.
a larger portion. And I think that's also one of the challenges and why we decided to go with a preventative approach that will address all types of cancers, because most people, even if they are dying from cancer right now, might not even know that they have cancer at the time of their death. So I think it's one of the challenges in tracking that data.
So what are the prevention activities, or the what preventive measures will you actually have in place that will prevent those types of cancers?
Divya, would you like to talk about this?
So one of our main interventions is this community camels. So this is kind of adapted off of a camel clinic that was already established in other parts of Africa. And so what those clinics did is they used camels to go to different parts of Africa, and they would kind of just teach about health education, treat like minor health issues. We're kind of adapting that as more of an educational approach. So we're going to use these camels to go to different parts of the community, educate about some of the different environmental risk factors that are present, such as clean water, some things that you cook with, just different types of education. We also want to teach about nutrition and potentially help the people there build these different types of cone gardens so they have more variety in their diet. And we're also using this as a way to increase employment as well.
And for example, for breast cancer, we would also like to teach the importance of self-exams and how they can go about doing that as well.
Thank you, guys. I have a related question, please. It sounds like a lot of the intervention is really targeting diet, but what I'm wondering is, are the common types of cancer in this population largely linked to diet? Like, are dietary modifications, or how are dietary modifications going to affect the prevalence of these particular cancers in this particular population?
Yeah, well, one of the major risk factors for developing cancer is obviously tobacco and alcohol use, which would be largely attributed to esophageal cancer and lung cancer and other types of cancers overall. But that is not an issue in this community. There is not a high rate of use of tobacco or alcohol. So that's why we decided to target through dietary interventions, and they're also extremely physically active already. So those are sort of the big four causes of cancer that we see. And so that's why we decided to go the dietary route, and also limiting environmental exposures and reducing poverty.
And here, just to jump in, the NMC, the Conservancy is already helping them do that. It's not that we are trying to change their diet overnight, which they have done for centuries. It just adds some supplements, some other things that they can grow. So NMC currently have a garden, but the whole community of 2,000 people do not access it because it's not spread out. So what we plan is to kind of help them with seeds and necessary training and educate them. And again, these training will be done by their community members so that they get to learn, hey, this is another option that you can take probably.
I have a question. Thank you very much, team. Two questions. I'll just ask both of them. Is, you've got the concept of the community camels. Are camels widely accepted as a mode of transport in this community? And I see you've got camels and motorbikes. Did you analyze the benefits of either against the other? So that is one. Then I'll just ask both my questions, and then yes. The other one is, I'm wondering about the the conversations you're talking about, confusing conversations. In terms of the health clinic, like the Sekanani Health Clinic, which is the public health clinic, how do you see your intervention building capacity at the existing, health facilities insofar as cancer specifically, be it prevention or screening for cancer or even treatment? How did you address that? How could the existing infrastructure be strengthened for this community?
So for the first question, you said about Camel. So Camel is, so there is an organization named Chat Africa, which already operates in 12 countries in Africa, including a part of Maasai that doesn't include this particular Maasai community, National Conservancy that we are working with. So they are already familiar with it, and it's already something done and proven successful in the particular community. So that's why we can try. Again, we are not saying that it might be successful. That's why we will try to do that. But in the immediate term, you saw that we had an intervention with motorbike. So we will give the people tools, the community health workers tools, they can screen and refer them to hospitals, right? So that's the thing that their immediate need. That's why we will give them 5 motorbikes for these villages. There are about 2,000 people, so that they can immediate needs, so that they can go to the hospitals and they get the care that they need.
And I can address the community conversations. Could you repeat the question? I sort of needed to be repeated.
Yes, I was wondering what the community conversations you talked about clearing up, confusion. And I was just wondering, with respect to like the public health clinic, what confusions might there be with respect to cancer in the community and use of the community or public health clinics?
Mm-hmm. So yes, one of the assets is that they already, of course, have a clinic, but one of the needs that was mentioned by Nelson and Maggie is that it's currently being underutilized. So it seems like they have quite the capacity to care for people, at least in a preventative way, or to complete screenings. However, people don't feel inclined to go there. They're more inclined to talk with traditional healers, which are great. And that's why we want to build relationships with traditional healers in order to, let them know you can refer people to this clinic if there's something that they need that you can't provide. And that's why we're having this community dialogue rather than just assuming that people are going to wholeheartedly embrace this clinic or wholeheartedly embrace any intervention that we do, because we know that they won't. And that's why we want the buy-in from the elders and the traditional healers. And then in terms of long-term goals for the clinic, that's why we have that strategic plan to secure funding for future screening opportunities that could link people to treatment. We think treatment is too expensive to think about in the next 20 years for that community, but that doesn't mean we can't start to incorporate secondary prevention and screening methods.
Okay, thank you.
Still have a minute for Q&A. Are there any final questions from the judges?
No, thank you.